Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Well, hello again. Welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar from Rehab Practice Solutions, where we fill healthcare clinics and organizations with engaged patients who value the treatment they are receiving at those locations. If you want to learn more about that, you can head on over to www.rehabpracticesolutions.com. That's rehab, the letter U, practicesolutions.com. This week, we are diving back into the world of interdisciplinary care. We're going to talk more about those factors that are not just the pathophysiological that may affect our clients or our patients' long-term health and clinical outcomes. Really had just a joy and pleasure of having a conversation with a former colleague of mine when I was a consultant for the Department of Behavioral Health and Developmental Disabilities here in Georgia. Her name is Josie Baker. We worked together on a project that was helping the state of Georgia achieve its goal of transitioning individuals out of institution-based care to more community-based and inclusive residential programs. So we did, we called it mobile integrated clinical support. So we did some clinical oversight for the state. We provided advisory and clinical assessments for folks in our state that were transitioning out. It was just a lot of really fun work that had a big impact. I mean, we were able to see folks that had lived in a state hospital or state institution sometimes for decades at a time enter their own home for the first time, right? Like, it was really, really fun work. And Josie and I worked together on that team, and she was a social worker. I was an occupational therapist and a community support specialist. And through our work together, we ended up doing a lot of projects and work related to interdisciplinary care, case management, all of that kind of stuff. And I noticed a while back that she had left doing that type of work and was now working with Soda Health. And I'll let her tell you a little bit more about what Soda Health is and how they aim to fix a lot of the issues with the social determinants of health in healthcare. But primarily what I wanted to spend some time talking with her about was the whole concept and idea behind the social determinants of health. If you're like me, maybe in the academic setting, you've heard a lot about the social determinants of health. You've seen the research come out about it. If you're a clinician, maybe boots on the ground, you might have heard it mentioned in passing, maybe at a CME conference or a CEU course or something like that. But the term itself can seem very ambiguous, very academic, very heady and intellectual, and it's hard to kind of draw the connect the dots, if you would, from this intellectual concept or this really 30,000-foot view of all of the factors affecting an individual's health, and then tying it to what do we actually do with this patient or with this person in the clinic who's sitting in front of me, who I know has XYZ factors that might be affecting their participation in treatment or their even ability to attend appointments and all of that, sort of the milieu in which these people, these patients that we serve live. So I wanted to have a conversation with Josie specifically about the social determinants of health, kind of a high level, define them, what are they, how do they impact an individual's health, and what can we as clinicians boots on the ground actually treating individuals, what can organizations or administrators, healthcare managers, and case managers do to actually affect change or support these individuals through some of the trying and the difficult times they might be going through. So hopefully this this conversation provides a little bit of insight about the social determinants of health. Hopefully it provides you some practical tips and resources. Josie has been gracious enough to send us a few links to some organizations that have resources available about learning more about the social determinants of health and then actual helping individuals find specific services based on their location. And we'll link to all of those links in the show notes. You can find those at rehabupracticesolutions.com. Just click on the tab for podcast, find episode, this episode, and then look on at the very bottom. We'll have all of those resources linked. So without further ado, here is a conversation with Josie Baker about the social determinants of health. Well, hey, Josie, welcome to the show. How are you?
Hey, Rafi, I'm good. And yourself?
I'm doing all right. I'm looking forward to talking about the social determinants of health and kind of diving into that topic. But before we do that, why don't you tell us a little bit about yourself, your work, and kind of what you're doing now with Soda Health?
Yeah, so thanks, Rafi, for inviting me to be on your podcast. Just to provide some background and context to the listener. So I am a social worker by profession. I'm certain your listeners have some general understanding of social work, but I would be remiss if I didn't acknowledge that there are some stereotypes about the profession. So just to provide some context that I think is also useful as we talk about social determinants of health today. Because certainly social workers view this as an important component of our work. But social work, as a profession, is devoted to helping people function the best they can in their environment. And so we believe in, the principles of patient-centered care, empowerment, and true assessment of need. And so as a social worker, I have worked predominantly and exclusively, frankly, in the state of Georgia, predominantly with individuals with intellectual and developmental disabilities. For about the past 10 years, I've been working with Georgia to achieve its goal of inclusivity and moving individuals from institutional settings. And through that work, really saw the importance of needs identification and developing true care plans for individuals such that they could achieve their identified goals. And as you do that, you also take a look at what are factors that would both promote an individual's independence and serve as barriers to them. And we'll talk about those factors today, but certainly, my work here in Georgia, where I currently reside, served as a great basis for the work that I'm doing now with Soda Health. So we are a healthcare technology company that's focused on building solutions to eliminate health inequities and create a healthier America. And so I'm able to leverage my experience both through my work with individuals with intellectual and developmental disabilities, and then also more broadly as a social worker, to develop solutions and products for the company.
Yes. Awesome. Thanks for that background. And it's worth noting that you and I worked together on a couple of those projects here in Georgia. That was some really impactful work, some fun times. We had a great team.
We did indeed, Rafi. It was a pleasure to work with you. And, I think that that's also something that we can highlight here for just a moment, is that social workers often work as a part of a broader treatment team.
Exactly, yeah.
And so it's really important for us to think about the partnerships that we can create with PTs, OTs, other clinicians and therapists to create meaningful change for our patients. And so it really takes a village, and working with you was a real pleasure.
All righty. Well, so we've had some guests come on the show before, and usually when the topic of social determinants of health come up, it's usually mentioned kind of like in passing, like, oh, obviously social determinants of health, yada, yada, yada. But I have a feeling, especially for like myself as an allied health professional, like it wasn't until I started doing some of the work with you and with Georgia that I really began learning a little bit more about it. So can you just define like just the term, like what do we mean when we say the social determinants of health?
Yeah, so just for ease, I'll start referring to social determinants of health as SDOH for the listener.
It's a mouthful, yes.
Yeah, it is a mouthful. but they're all the factors that impact a person's health. And so they're the non-medical factors that affect health outcomes. So the World Health Organization defines SDOH as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems that shape daily life. And so as we engage in our conversation today, it's important to note now that while healthcare is essential to health, research tells us that it's a relatively weak health determinant. And so addressing SDOH also endeavors to reduce health disparities that are often rooted in social and economic disadvantages.
Yeah, so sometimes it's not just getting access to care, but there's also things like the 5 categories, right? There's economic stability, education, healthcare access, the living environment, and all of that. Maybe we can talk a little bit about kind of each of those categories and how they can affect an individual's health. Because sometimes some of it is obvious, it's pretty obvious. Like if you can't afford to go to the doctor, there's economic impact affecting your health, right?
Right, absolutely. So yeah, I appreciate the way that you've organized that, Rafi. This is such a broad topic that bringing some structure to SDOH is often helpful, particularly for those who may be new to the topic or hearing about this topic for the first time, but might have some general understanding of the themes. But I do want to mention that SDOH can extend beyond the 5 areas that I'm going to hit on today. And so there are some great tools from the World Health Organization and other government departments that your listener can access online that goes into greater detail about some additional factors. But yeah, let's talk about them. Let's start with economic stability because that often underpins so many of the other things going on in a patient's life. So according to the Census Bureau, about 1 in 10 people in the United States live in poverty. And so when we think about economic stability, we're considering a person's access to employment, and that extends to job training as well, stable, affordable housing, and food insecurity. So all of those factors that income can affect, we would view as being a part of economic stability. And so when we think about patients, we know that for those who experience this particular factor, they're having to make difficult decisions frequently, and they may have to sacrifice in one area such that they could maybe get the care they need. So for example, if childcare is an issue, a patient may not be able to afford childcare. So they may forego, a clinic appointment and elect instead to provide the childcare for their loved one. And so those are the types of themes that we're thinking about. And with economic stability is just general income and barriers to, having a stable income and being able to afford utilities and the like.
Yeah, it's funny. I think especially being in the clinic and seeing patients from all walks of life come in, that seems like something that comes up pretty frequently. And like you said, I'm shocked by the 1 in 10 Americans living in poverty. To me, that seems extremely high, especially for the most wealthy nation on the face of the earth, right? But it is something that we come in contact with a lot. And it is something that we work with patients that come in, and we're going to try to schedule, and we'll try to make it work so that it works for your finances. But I think that all happens sort of administratively, almost like we're taking care of that from an administrative standpoint in order to get the patient to the clinic or in order to do XYZ. But we don't often, at least clinicians often don't think about that as being almost directly tied to that individual's health and their health outcomes, right?
Absolutely. And Rafi, I think maybe, as our conversation today evolves, we'll talk about how to assess for need in this area, but you bring up a great point that sometimes we identify what the need is, but don't know how to address it in a way that is truly patient-centered. So yeah, that's economic stability. I know there were a couple of others that you wanted me to highlight. So for example, education. So here we're thinking about access to quality education, frankly. We're thinking about things like literacy, which for the listener, I think is important to note too, that general literacy also affects health literacy.
Yes.
And we know that oftentimes patient outcomes are associated with their ability to understand the medical information conveyed to them by a clinician, by a physician, et cetera. It's also access to early childhood education and all of the important developmental milestones that occur and how, parents or others caring for children are able to navigate childhood development and provide the educational resources that a child may need. And access to vocational training or higher education. And so again, thinking about economic stability, which we've just addressed, education is so critical in terms of being able to obtain and maintain employment. And so all of those things combined make up education as one of the social determinants of health.
Yeah. And it is one of those, it's the more and more you dig into this, the more and more you see that how it's not an easy fix, right? Like, well, you got to get, economic stability in order to improve health outcomes, but economic stability, like the underlying factor could be education. Well, now you got to fix the education system. And I'm sure we're going to dive into living environment and how that affects education, right?
Absolutely. It's all interconnected, truly. And that's why addressing, one SDOH factor in a silo is not going to, it is my opinion that it's not going to make meaningful and lasting change for a client. And so when we think about something like healthcare access, for example, we're thinking about access to healthcare coverage. For those who may be eligible for Medicaid or Medicare as well, providing education to them about their eligibility and supporting them through that process. We know that can be arduous and they may need support in that endeavor. For those who do receive healthcare coverage, we also know that there are sometimes disparities in provider availability, rural versus urban settings in particular. And we think too, to your point earlier about transportation, if you live in a rural setting and the nearest provider is say 50 miles away, transportation can be a barrier to accessing care as well. The other thing to note here within the context of the healthcare system is the provision of culturally and linguistically competent care. And that ties to health literacy, as we previously discussed, but providing information, providing care to a patient in a manner that's consistent with any cultural considerations and in a manner that is consistent with any language considerations, so that we meet patients where they are and that they can engage fully in their treatment. And then just general quality of care. Certainly there's a body of research now about outcomes for those who had COVID-19, for example, and geographic areas where they received care and related outcomes. And so, I think that's important to note here as well is the zip code component. I don't know if you know this, Rafi, but sometimes zip code is considered to be a greater predictor of health than your, genetic background.
That's a crazy fact.
It's very crazy. And so I think that's an important thing to note here as we talk about our healthcare system. And then living environment. So there we're thinking about housing stability, accessibility as well for any people who may have disabilities, being able to have accessible homes, the affordability of housing. I think we'd be remiss if we didn't take note of the rising cost of housing across our country, and how because of that can lead to some transience for people, and that the impact of having an unstable housing can be very challenging for people. Also, the living environment is also a part of your broader neighborhood and community context. So availability of grocery stores, pharmacies, again, playing into the healthcare system, availability of doctors and urgent cares and ERs, et cetera. Those are all things that are tied to the living environment. We also should note here, Rafi, that there are things that we would need to assess further with a patient. But for example, pest control, right?
Yeah.
So that's something that until I took this job, maybe I hadn't fully considered, is just how important it is to assess for things like pest control, and how a patient may be, unwilling, quote unquote, to allow a clinician into the home. And it could be because there is indeed an infestation of some kind. And so I think it all, again, speaks to the quality of housing and the safety of that housing as well, both in terms of the structure itself and overall neighborhood safety.
Yeah.
And then lastly, of those that you wanted me to discuss today, the social and community context, so things like social integration and social support. We know that social isolation is a considerable risk factor, particularly for older adults. And so, how can we address social isolation and promote inclusion? Also, the broader themes of discrimination, of stress in environment, I think is important to note in the context of community and social as well. So those are broad themes. Again, there is considerable research on SDOH that I would encourage your listeners to review should they be interested in these topics, because I think that it does have implications for patient care and development of treatment plans.
Yeah, we'll try to link to like the World Health Organization and stuff in the show notes. I think one of the things you mentioned there at the end, like the isolation and loneliness and all of that kind of stuff, obviously with our work with folks with developmental disabilities, it's a little bit more obvious and pronounced. Somebody that's alone and doesn't have any support system other than like paid staff that's caring for them. Obviously, they're in a much tougher spot. But even in folks in their day-to-day life as we age, I've got a neighbor I'm thinking down the street it was her and her husband, and her spouse died maybe a couple months ago, and there aren't any cars coming in and out of her house. So
Right.
like somebody like that who is quote unquote healthy or typically developed or whatever can still be at risk for really some negative outcomes just from social isolation, right?
Absolutely, Rafi. And I think that's why it's important, to the extent possible, to build community. So you've taken note of a neighbor who had a significant life change, and how we can, even at a very individual level, not even within the clinical context, but how can we really reach out to people and help them when we know that there's a change in their circumstance. And so I think that I know that your listener base is predominantly those who are in, allied health. But I also think it's important to note here that we, just as, citizens, can do our part to support our neighbors around these very issues.
Yeah, be the change you want to see in the world, right?
Yeah, couldn't say it better.
So while a lot of these topics obviously are very important, and it's a very, very broad topic, it can often sound, heady or academic even in nature. I'm a former professor by trade, so I'm like thinking about the research and the implications and this, that, and the other. But it can seem very almost something as an intellectual exercise, right? But I'm sure there are some real world implications to these concepts that clinicians and healthcare professionals may often overlook in their day-to-day interaction with patients, right?
Oh, certainly. And I think, you set us up for success with this particular question with your reference to your neighbor. So let's just take that for just 1 second, right? So if an individual, has a loved one who served as primary caregiver and passes away, I mean, that creates likely a financial burden, could, have implications for access to transportation, and generally, navigating their care, particularly if they're grieving. And so, yes, these concepts are indeed, kind of intellectual in nature. But I think that when you break it down and take a look at just the person and you think about what is impacting them, it makes it a little bit easier to digest, and it makes it more applicable to both personal and professional application. But here's what I'll say in response to your specific question, Rafi. Speaking as a social worker and someone now in the healthcare industry, I think it's critical for clinicians to consider the entirety of a patient's experience when developing a treatment plan.
Yeah.
So, I think about some of your past episodes, you've talked about the importance of like a biopsychosocial approach to identifying patient need. And I think that plays in nicely to the conversation that we're having here today. So because both directly relate to SDOH. And, clinicians could also consider adopting a social needs assessment as part of like their standard intake process. So I hope your listeners don't accept this as like an endorsement of any particular tool. I'm merely sharing a resource here. So for example, they may consider the PREPARE tool. So that stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. So as noted in their toolkit, it's a standardized patient risk assessment tool and a process and collection of resources to identify and act on SDOH. Likewise, the American Academy of Family Physicians has a social needs screening tool that's pretty quick and easy to use. And I'm sure you'll put this in the show notes, but I would also recommend to your listeners, if they're interested in social needs assessments, that they take a look at the University of California, San Francisco's Social Interventions Research and Evaluation Network, or SIREN. They have an evidence and resource library that includes recent and historical research on SDOH, as well as a social needs assessment comparison table. So there's a way to access their website to take a look at what social needs assessments exist and then compare them based on what a clinician may need to be looking at. But the other thing I'll say, Rafi, you asked about overlooking patient needs. As clinicians develop care plans with and for patients, I think it's critical to consider what factors may impact their treatment progress and healing, and how a clinician can address those specific issues.
Yeah.
So I would suggest, again, I've never been in your shoes, Rafi, as a therapist, but I would say, that assessment of SDOH factors shouldn't occur only at intake. Rather, it should be an iterative process occurring throughout the treatment relationship. And really, I think that it plays directly into the development of a care plan for the person. So, for example, does your patient have access to transportation? Is their wound not healing properly because of their diet and access to healthy food? Does a patient feel comfortable using or do they have access to technology? So those, I think, are the kinds of things that we should be routinely taking account of and thinking about in our work day to day with patients.
Yeah, and just like we should be obviously all those objective measures and the things that we're looking for from a reimbursement standpoint or even like a clinical outcome standpoint. Like if you're reassessing the patient every time they come into the clinic, like it does not take a lot of extra effort to put some of this thought behind the questions you're asking your patients and kind of probing into some of those areas where that might really be impacting their outcomes in your clinic and with the treatment that you're providing, right?
I agree, Rafi, and think of it this way too. You might be the only person asking the question. Think about how impactful it is, right? So if you've got a patient who comes in and you're just administering an assessment, you might be the only person who has asked them, let's talk about your food security. Let's talk about your transportation. And so unless there's oftentimes it's been my experience, and unless there's somebody who's willing and able and positioned to provide some assistance, sometimes these needs will go unaddressed for a very long time.
Yeah.
And so I think that to empower your listeners to, implement assessment I would love for that to be a takeaway today. Is that we should be assessing patient needs, and that there are tools, evidence-based tools that already exist that would empower a clinician to do just that.
Yeah, and that kind of leads into this next question here. So, like, let's say you are working in a clinic or maybe in a hospital, community-based setting or something like that, and we become aware as a clinician of a certain patient or particular patient's risk in one of these areas. Are there generally resources available in some of these circumstances, or does it depend on things like, health insurance plan or carrier, or even, I mean, obviously zip code seems to be a big one. Like, are there grants available? Like, what sort of resources are available to clinicians if they realize, okay, patient A here has a real significant need in, let's just say housing or something like that?
Mm-hmm. Yeah, that's a great question, Rafi. So I think that it's a combination of things, right? So before we jump to specific resources, how to identify them, I think I'd be remiss if I didn't highlight some patient choice here. So when we look at research about patient needs assessment, social needs assessment, I found a pretty consistent theme, and that is that outcomes improve when patients prioritize their needs. So, I even reflect a lot on my work as a social worker. I spent a lot of time telling people what I thought their needs were. I think that was sometimes it contradicts the work that I was supposed to do as a social worker. I think about that a lot, but really working hand in hand with the patient, I think, to identify what is their most pressing social need and what can we do to address that. And I think that we can have and should have some lively discussion or debate about things like patient insight, because I'm sure that's something that your listener will be thinking about. What if the patient has impaired insight? We should consider that. But by and large, I think that patients are generally the experts about their personal lives. And so as we consider things like resource identification, I think it's necessary for a clinician to work collaboratively with the patient to determine which issues take priority for them.
Yeah, I think that's such a big piece. So we always, we talk about being clinical experts all the time. We have this knowledge and this expertise. And one of the previous guests on the show said, well, you should think of yourself really as a knowledge translator, right? Like, we're taking the vast technical knowledge that we have from our training and we're bringing it to bear on the client's specific situation. But to your point, that client is the expert in what's going on with them, which is why we can't just dictate to patients, well, this is what you got to do and you're going to get better, right? Like, there needs to be a collaborative effort in the development of a treatment plan or a plan of care or something like that. So, sorry, cutting you off, going into resources.
No, I'm so glad you did it. And just to add to that, Rafi, I think that I like that concept of being a knowledge translator. I think that's really smart. I think too, when we say to a patient, this is what we know clinically you need to do to get better, perhaps an extension of that conversation can be, clinically, we know this is what you need to do to get better. Well, how can we work together? What is a barrier to that? Or thinking more positively, what systems or structures are already exist for you that will support you in this treatment plan? But let's talk about resources. The social worker is certainly a topic that we discuss frequently because we like to think of ourselves as brokers of services. I think one way to look at this is to think about the individual's insurer. Some insurers may have benefits that could address a member's, specific SDOH risk factor. So, for example, there are some Medicare Advantage plans that have transportation benefits. And so having, some knowledge of the individual's insurance is prudent because their insurer may be able to bring some resources to bear. Clinicians can also access lots of resources online. For example, findhelp.org, where you can search based on zip code, and it will generate a wide range of resources based on that individual's zip code. and it's quite helpful and easy to navigate, in my opinion. But certainly there are other resources like nonprofits and other, web-based tools where you can search for services. Again, there are government benefits like, Lifeline, which helps to lower the cost of phone and internet. We know how internet is so important these days, particularly with telehealth. Things like, Supplemental Nutrition Assistance Program, or SNAP. A lot of people still think of that as food stamps, but that SNAP is now its formal name. And then lastly, things like the low income home energy assistance program that helps with things like energy costs and weatherization. So there are a wide variety of resources that exist, Rafi. I think that a patient may need help to find them.
Yeah.
May need help in determining what their eligibility is for those resources and applying for them. But also patient willingness is a factor and geography is a factor. And so what may be available to someone in an urban area might not be available to someone in a rural area. So I think we just have to consider the totality of a person's experience to determine, what might be out there for them.
Yeah.
But again, I think there's lots of insurance-based, web-based resources out there that patients and clinicians alike can look into to find some help. Yeah.
Yeah, I was not aware of the insurance thing until we had a patient come into the clinic maybe 6 or 7 months ago, and she had some significant needs from an economic standpoint. Like she was having to choose whether or not she was going to pay her energy bill or buy groceries, right? And she was Medicare eligible, and we just have a resource here at the clinic that we use, one of our local agents here, and he ended up being able to get her just navigating the plan she already had, the Medicare Advantage plan she already had. There was a benefit in there for using a portion of their benefits to cover utilities or something like that. So she was able to kind of cover that, and it was at no extra cost to her, and no one really knew about it at all. It just happened to be one of those, we were chit-chatting, or she was chit-chatting with the insurance guy. He just happened to be in the clinic, and it was like, oh, well, did you know XYZ? And it's like, no, I feel like unless they're explicitly advertised or something like that, most people don't even know what kind of benefits are even available to them in some of these plans, right?
I agree with you. And I think that also highlights, the importance of patient empowerment. Yeah. So what you all did in that specific example was increase your patient's knowledge about her health plan. I mean, how incredible is that? So that she then knew what she was entitled to receive, and perhaps she was further educated about other benefits that were available to her. And so I think that clinicians also have a responsibility, to the extent that it is within their scope of practice, to empower a patient to gather all the information that they can about their health plan and about their broader community. Because certainly we would want a patient to feel as though they are able to the extent possible, independently navigate their care, because we won't always have a person who can case manage. Absolutely. Yeah.
Yeah. Well, and kind of on the line of insurance providers, like, do you see them as a broad industry trend or whatever? Like, are they beginning to be more concerned about these social determinants of health, or why should insurance companies even care about social determinants of health, right?
Yeah, so thinking about the importance of SDOH, they account for 80 to 90% of a person's health. I mean, that's an incredible statistic. And so if a health plan is going to focus on the whole person, they have to pay attention to SDOH.
Yeah.
Now, I will say that health plans are constrained by the funding and reimbursement mechanisms that are already in place.
Exactly.
And for any service that can't have a health claim attached to it, it just adds a layer of complexity, which can also significantly impact scale. So yes, I think that health plans should be concerned about SDOH. I think we're seeing a trend in addressing these issues, but we also understand just how challenging that can be.
Yeah, again, there's no easy solution, right?
Right, never.
Well, we're coming near the end here. So I always ask this of folks, if there's like one or two main points that you'd want a listener to walk away with from the episode, and I think you've already mentioned it, but what would it or they be?
Yeah, so again, I think that my primary highlight here is that clinicians should be assessing for social needs. Again, it may be the only time that a person is being asked about their needs. And so, how incredible that is to ask a patient, hey, what's going on? And assist them with identifying resources. So that's my primary takeaway. The other, of course, is once you identify that a need exists, being empowered to help a patient get some resources and services in place to address those issues. And again, I think some of it, Rafi, is not just assessment, but also just merely observation. So if you see something that seems different about your patient, let's talk, what's going on and what can we do to work collaboratively to address that. Yeah.
Wonderful. Well, Josie, thanks so much for taking the time. If people want to find out more about you, about Soda Health, about y'all's work, where can they do that?
Yeah, so we would love for your listeners to learn more about Soda Health. You can look us up online at telehealth.com. And you can take a look at the members of our team and our background and what we endeavor to provide as solutions, to address those health inequities. And the last thing I'll say, Rafi, about Soda Health, because I think it just speaks to how we value this issue so closely, is that our CEO is also a social worker by profession. And so it's a very interesting place to work, and certainly we understand just how important SDOH is in making some changes within our broader health system.
Yeah, wonderful. Well, thanks so much, Josie. You have a good day.
All right. Thanks, Rafi.
Well, I hope you enjoyed that conversation. I think one of the things I love about doing this show in particular is it gives me an excuse to have really interesting conversations with really accomplished and really interesting people, right? At the time, before Josie left to do what she's doing now at Soda Health, she was running and managing a lot of the crisis work here in Georgia. She's just a very high-level individual. Even when working with her on the consulting side of things, when we were consultants together, she's a person who cares very deeply about the people that she's serving, and she just operates at a very high level. And I love having conversations about topics with folks who are experts in them, right? It just provides a level of insight that you cannot get from reading the research articles, from even reading, watching videos and reading articles on even publications and websites about a specific topic. Unless you're dealing with somebody or you're having a conversation with somebody who has really not just learned the concepts, mastered the concepts, but really implemented in daily practice, you're always kind of left short, right? So one of the things now, looking back or listening back to this conversation before publishing it, that stepped really into the forefront and kind of was highlighted again, was the idea of, obviously we talk a lot about taking a biopsychosocial approach on this podcast. Everything that we do at RehabU, the clinic that I run here in Augusta, we very much value and try to prioritize understanding an individual client's specific situation and their specific needs given their context and their injury or their diagnosis. Because unlike textbooks, people are very different. And two folks that have the exact same diagnosis, maybe even the exact same etiology, may be coming to the clinic or coming to their treatment from a wide varying background, right? And part of that does involve the actual factors that are directly impacting that individual's experience of their pain, for example, or their interaction with the healthcare system. But taking it a step further, understanding those social determinants of health and understanding some of these, as Josie and I talked about, some of these are really wide-ranging issues that we're not going to be able to fix. I'm not going to be able to fix somebody's the education system, for example, or the environment in a zip code in which they live. But understanding those factors at play helps me, one, as a clinician, tailor that treatment plan to be more specific to that individual in their context. But then I feel like, especially as a clinician that's been doing this for a number of years in the clinic and teaching at the university and kind of advising folks on how to implement systems like this, a lot of times that's kind of where it stops. We don't, because of our focus, and again, part of this might be the reimbursement model, and we're in this fee for service, and we can't spend time on unproductive or unbillable effort or resources, right? But a lot of times, especially as Josie said, allied health professionals, we might be the only person that is asking this individual about nutrition or housing security or employment or whatever the factor is that might be affecting their long-term clinical outcomes, regardless of this diagnosis or this healthcare engagement or encounter, right? A lot of times we'll take note of it. We'll put it down in the treatment plan. We might even tailor the treatment plan around that individual circumstances. But for the most part, we do feel kind of inept or unable to help this individual achieve meaningful gains in those specific areas, right? Like take, for example, somebody that is maybe making a decision between paying the copay at the clinic or keeping the lights on at their house. Like, how are we supposed to change that? How are we supposed to affect the change? I think part of that is doing it on a person-by-person basis and understanding that there are resources available. That's why we're going to link to everything that Josie mentioned and referenced on the podcast. We're going to link to that on our website so that you can find it under the show notes, because some of the resources like findhelp.org or whatever is a very good resource to help achieve some of that for the patient, for that specific patient, even though it doesn't fall under our purview, right? There's nothing wrong with taking a little bit of extra time and connecting a person with a resource or a person or a tool even that can help them achieve these outcomes in other areas of their life. I keep thinking of this example of these individuals that we've had that have issues with transportations or utilities or whatever it is, and simply just not knowing that their Medicare Advantage plan, for example, provides some of those benefits to them, and they're just not accessing them because they didn't know about them. So we always like having a qualified or a licensed insurance agent that we know and that we trust who can help walk somebody through that. Like, this is the plan they have. What are they missing out on, or what possibilities are there for them to help, pay the light bill or get transportation to their medical appointments? And a lot of times it doesn't take any extra money. It doesn't take any extra time on the clinic's behalf other than making the connection. And then this individual ends up really overcoming a big barrier, a big hurdle that might prevent them from receiving the care that they need. So definitely this is one of those super important, super high level topics that really is going to be, I would imagine, taking more and more of center stage in our discussion, both as an industry, healthcare as an industry, but also in society and politically, as we discuss like kind of how we improve the health of a nation, the health of a population in general. So that's all I've got for now. Hopefully this conversation was insightful, and I hope at least it gets you thinking about some of those factors, some of those social determinants of health that might not be directly connected to whatever diagnosis or whatever symptom or ailment has brought a patient into your clinic, and begin to really think about how you can be the change that you want to see in the world, for lack of a better term, because this is one of those topics that, again, it's one of those issues. It's such a big issue. It's so complex that we are not going to see, at least this is my personal opinion here, we're not going to see a solution arrive from government policy or regulatory implementation or Even at some levels, giant corporate work, right? I think that in order to really affect change in some of these areas, as Josie mentioned, it's going to have to be sort of an individual citizenship and sort of a community building that takes place. It's going to have to be individual clinicians or individual people, because that's ultimately what healthcare is. It's one person that's skilled in the art of healing, helping another person who is on their own unique road to recovery. And it's not until that relationship is truly restored and truly functioning the way that it should that some of these larger issues can be addressed. And because again, everybody's different, every circumstance is unique, and it's very hard to get some kind of blanket governmental policy that's going to fix it. Again, that's just my personal opinion, that I think that if we really want to see some real changes in some of these areas, it takes individuals stepping up to the plate when the time arises. So that's all we've got this week, folks. If you like the show, head on over to iTunes, leave us a rating and review. Helps people find the show. If you want to be notified when we drop new episodes, you can head on over to www.betteroutcomes.show and sign up there. We'll send you an email with a link to the show notes, and all the resources whenever we drop a new episode. We tend to release episodes every other week on Wednesdays. Sometimes there'll be a bonus episode that drops on the off weeks, but I think I mentioned this a little bit ago. I'm in the middle of writing a book about healthcare, about humanizing healthcare, and that's kind of taking all of my free time and my spare time here. So probably no bonus episodes until that gets done. Hopefully that book will be released mid to late 2022. So until the next time, folks, be safe, be healthy. I will talk to you then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabuppracticesolutions.com. We'll catch you on the next episode.